So welcome all. Today we'll be discussing about ERAS protocol. So the ERAS protocol is coming under the perioperative care module, and it's one of the frequently asked topics in the Royal College of Surgeons MRCS party examination. So we'll be dealing this at a basic level, and the first thing that we need to know about ERAS is it stands for Enhanced Recovery After Surgery, and this was basically started in the colorectal surgeries, and it was started around 20 years back. Almost 2 decades we have passed through the ERAS protocol, and today ERAS protocol is an active area of research which is implemented in almost all major GI surgeries, hepatobiliary surgeries, upper GI surgeries, and it's extending more into other domains like the cardiothoracic surgery, vascular surgery, and so on. So the list is not ending. The research is going on, and one thing we need to know about ERAS protocol, it's a protocol which has been established in the West, established in the US and the NHS, and mainly it's covering all those elective surgeries. So if I say that you apply the ERAS protocol in a patient who is planned for emergency surgery, it may not be much of a meaning. So the third thing is, why ERAS protocol? So why such a protocol has to be followed? That's a big question. And surgeons 20 years back, what they were doing with the patients, that is the answer to this question. So 20 years back, those surgeons who were operating for the colorectal surgeries or the Whipple surgeries, whenever they planned the surgery, so they had exposed the patient to enormous amount of stress, and the reasons could be many. And the first thing is that the surgery itself is a stressful response, and there was no proper analgesics usage in the past, and this further lead to pain, and the use of anesthetic medications which were causing more issues with the nausea and vomiting, and the routine practice of keeping the patient NPO for a very long time, which is ideally a very bad practice. It's even followed today by many surgeons, but actually it's a quite hazardous practice of keeping the patient NPO for quite a long amount of days after any GI surgeries. So immobilization and fasting. So all these were leading to very bad outcomes in terms of the perioperative outcomes of a patient. So that's why the ERAS protocol was initially aimed at a set of timeline events to prevent all these factors, so that the outcome of the patient in the perioperative period is good. And the main outcomes that they have mentioned is the length of stay in the hospital, and the amount of expenditure that has been reduced, and also the decreased complications. So there was a recent question on which is the key factor which is important from the ERAS protocol, and the most ideal answer to that question is length of stay. So the second thing is that let's see what are those events which are put forth in the preoperative, intraoperative, as well as the postoperative period. So whenever we receive a patient planned for surgery, and in the preoperative period, first thing that you need to do is counsel the patient, because counseling the patient can alleviate the stress in the postoperative period. So that's a very important step which needs to do, and the patients have to be nil per oral for solid foods after midnight, and clear liquids are allowed until 2 hours of surgery. So this is where the concept of carbohydrate loading was introduced in ERAS. So because these patients who are undergoing major GI surgeries, they will be for a period of fasting and also immobilization, and this might lead to what's known as the insulin resistance in the postoperative period, which might be hazardous in the perioperative outcome of the patient. So that's why the carbohydrate loading was introduced in the ERAS protocol. And very well, this is one of the latest question in which they have asked what is the purpose of carbohydrate loading in the ERAS protocol, and the answer was to prevent insulin resistance. So also we need to have proper analgesia for the patients 1 to 2 hours before the surgery, and if there is facility for thoracic epidurals or epidural catheters or a tab block, that also should be used. And also post-operative nausea and vomiting prevention by means of a scopolamine patch can be utilized. So after doing all this in the preoperative phase, we'll be shifting the patient to the OR, and then starts what's known as the intraoperative phase. So in the intraoperative phase, the most important thing is the judicious use of fluids, that is the goal directed fluid therapy. So previously what the people were doing is they were loading the patient with fluids in the intraoperative period, especially in those major surgeries like Whipple's and all that. The patients are exposed to a lot of fluid loss because the duration of surgery is around 8 hours, 6 to 8 hours. So there was a lot of fluid usage in the past which were leading to hypoxemia in the postoperative period. So that's why the concept of goal directed fluid therapy was used. And fluids like normal saline, and they were less used, they were not preferred much. And the usage of normothermia in the operation theatre can have a very good effect in the perioperative period. So normothermia means maintaining a temperature which is more than 36 degrees centigrade, and adequate oxygenation of the patient is very important. So the analgesics should ideally be continued in the intraoperative period, and this can be in the form of the intra thoracic epidurals or epidural catheters, or ketorolac patch, ketorolac IV infusions. And also the postoperative nausea, vomiting prophylaxis has to be continued. So a chlorhexidine preparation of the skin is ideal, and skin shaving is strictly prohibited. It's good to have a proper glycemic control during the intraoperative period, and keeping the glucose less than 180 milligram per deciliter, because this might lead to increased chances of SSI in the postoperative period. And most importantly, the usage of intraoperative antibiotics 1 hour before the incision time is quite an important thing, which is also asked recently in one of the examinations. So the one thing which that we must know is the usage of minimally invasive techniques by means of laparoscopy or a robot or a short incisions can have good outcomes of the patient, because studies have shown that whenever the incisions are more than say 20 centimeters, it leads to increased amount of surgical site infections. And also judicious use of blood transfusion, all these are important parts of the intraoperative management. So after the intraoperative management comes the postoperative management, which is quite simple and easy. That in the postoperative period, the patient should be having a strict fluid balance. That means you should not load the patient with fluid, and it should be a proper balance between the positive and negative. And also the early milestones like avoiding usage of nasogastric tubes or any other drains, because these will prevent the patient from mobilization. And also the analgesics has to be continued in the postoperative period in the form of NSAIDs or gabapentins. and these analgesics should be non-opioid. So early enteral nutrition is another important thing which needs to be kept in mind when we are dealing with ERAS protocol, so that we prevent the translocation of bacteria in the gut. And following all these things, we have what's known as a successful ERAS implementation, and the main important thing is the outcomes. The main important thing of ERAS protocol is the outcomes. We are worried more about the outcomes, and the better outcomes that we can achieve with the proper ERAS protocol is increased patient satisfaction and better outcomes in terms of decreased length of hospital stay and decreased cost of healthcare, and also decrease post-operative complications. So this concludes this module. And frequently the questions which have been asked are, why do we do a carbohydrate loading, and what is the role of skin shaving, and what's the usage of antibiotics, and the fluid balance in the post-operative period, usage of non-opioidal analgesics, and what's the most important outcome from the ERAS protocol. So these are the questions which have been asked in this chapter. It's quite an important topic, and you can expect 1 to 2 questions from this topic.